So we'll move on to our vascular topic for the day. This is completing the red takeover of Grand Rounds for this week. So we have three different presenters. Brandon Philbrick, who is one of our no longer junior residents, now mid-level resident, doing research. He completed his undergraduate work at Georgia Tech in biomedical engineering before going on to Emory, finished his stint as an outstanding junior resident, and is now looking ahead to the rest of his career. And for reasons that remain unclear to me, has chosen vascular. So he is going to be sort of among our, he very gamely welcomed my invitation to join his two faculty mentors to present this week. And he's going to be talking about intrasaccular devices. And then we have Dr. Kellner, who everyone here knows well, an associate professor of neurosurgery and director of the ICH program. And it turns out he does many other things aside from ICH. So he's going to be talking about some of the trials that our group is doing for endovascular devices, as is Dr. Majidi, who also completed his endovascular training here and is an assistant professor in the department and director of cerebrovascular services in Mount Sinai, Brooklyn. So welcome to all three of you. Looking forward to hearing about the latest and greatest in endovascular technology.
All right, thank you for that introduction. Go ahead. Is everything looking okay?
Looks good.
Great. Okay. So the title of this talk is going to be Cutting Edge Aneurysm Technologies. I really think that this is going to be somewhat more of a warm-up discussion as to get ready for some of the devices that Dr. Kellner and Dr. Majidi are going to be discussing later this morning. And I'll be giving more of a broad overview about where we've been and where we're going with aneurysm treatment in the endovascular space. All right, just jumping into a really quick background, the currently recognized aneurysm prevalence is around 3.2%. However, this rate has been rising over the last couple of years. As recent literature comes out, we're starting to detect aneurysms with increasing frequency on patients that are getting vessel imaging, usually for other unrelated reasons. I've seen some papers say that the rate is coming up to as high as 5%. Some are even pushing even closer to 10% rate of incidental intracranial aneurysm. The rate of rupture in the general population is approximately 10 per 100,000, with, as we all know, very high rates of mortality and morbidity. And then subarachnoid hemorrhage is about 0.5% of all-cause mortality worldwide. Ruptured or high-risk aneurysms are typically considered candidates for treatment either through an open surgical or an endovascular approach. And treating these aneurysms is very highly specific to the patient's aneurysm anatomy, as well as factors such as their age, rupture status, different medical comorbidities, as well as overall just patient preference. I think it's hard to discuss what the most modern treatments are and therapies and technologies and aneurysms are without going back and seeing where we've been to get a better sense of where we're going. In prepping this talk, I did a lot of reading about aneurysms overall, both in the peripheral vasculature as well as the cerebral vasculature, and I was interested to see that aneurysm treatment really goes back to the 1700s when there was a group of physicians in Europe that postulated that introducing foreign devices into an aneurysm could induce thrombosis within the aneurysm sac. And this work started actually in canines that had thoracic aortic aneurysms, where they would insert needles into the aneurysm to try to get them to thrombose. And about a century later, there was a physician named Charles Hewitt Moore from England who actually took the work of inserting needles into an aneurysm and thought that, well, maybe an implantable metal coil wire would work better. So he actually inserted 26 yards of coil wire into a thoracic aneurysm in a patient via an open approach with a needle puncture into the aneurysm. They did find that the aneurysm shrank in size and the patient's vitals did improve compared to pre-op. They were no longer tachycardic. Jumping forward again, we start moving into the treatment of cerebral aneurysms, where Walter Dandy performed the first surgical aneurysm clipping. And then only 3 years later, there was a group of physicians across the park at Columbia University that performed the first coil embolization of an intracranial aneurysm, where they did a percutaneous transorbital coiling of a giant right paraclinoid aneurysm. And they used 36 feet of silver wire for this to treat a teenage girl that was going blind and having pituitary dysfunction from her large aneurysm. These photos over here were actually lifted from the case report of this study, which was published in JAMA in 1941. And I find it incredibly interesting that they were able to diagnose this aneurysm just by looking at the bony erosion it was causing and and how it was displacing the anterior clinoid and invading into the sella. Moving forward through the 20th century, there was a group at Georgetown University who did the first selective catheterization of the internal carotid artery, and they were able to temporarily occlude a PCOM aneurysm by using a balloon. So this was the first time that we'd really shown that we could get endovascular access to these types of diseases. About a decade later, we started having detachable balloon tip catheters, which were developed and used for aneurysm occlusion. And these were being deployed in patients with, although they were not very efficacious, it was the first time we were able to treat these aneurysms through a purely endovascular approach. Also in the 70s, we started having modern metallic coils start to come onto the market for treatment of peripheral vascular aneurysms, which were then followed by manufactured coils for cerebrovascular aneurysms in the 80s. In 1989, there were detachable coils that were developed by a company called Target Therapeutics, called the Guglielmi coils for cerebral aneurysms. And this type of technology is actually still in use today. And this is a photo of Dr. Guido Guglielmi and some of his colleagues celebrating their achievements in this space. And if some of you may recognize the name Target Therapeutics, this is actually one of the most common brands of coils that we use, which is now being marketed and sold by Stryker. And then moving forward to 2002, the ISAT trial, which I'm sure most of us or all of us are familiar with, was published in Lancet, which demonstrated that there were superior clinical outcomes with endovascular coiling versus microsurgery and ruptured aneurysms in a select patient population. And then the results of this trial really kind of exploded the market with both neurosurgeons and industry working to expand this field and see where we can push these technologies. So I'm going to give a brief overview of some of the different ways that we're able to treat aneurysms via endovascular approaches, starting off with the most common, which would be coil embolization. The technique of this is inserting detachable metal coils, typically they're platinum, into the aneurysm sac, which is delivered by a microcatheter. The real goal of coil embolization is to create enough packing density that you get stasis of blood within the aneurysm sac itself, then causing thrombosis, and then you get fibrinous changes of that aneurysm, and then eventually completely sequestering it from the parent artery. Some of the indications for doing pure coil embolization would be saccular narrow neck aneurysms, and it's also the most common technique that we use in ruptured cases, as well as very commonly in unruptured cases too. Some of the limitations for this technique is that it's very difficult to coil a tiny or a giant aneurysm without having any other assistive devices. Wide neck aneurysms are very difficult, as the coils will tend to prolapse into the parent vessel. Partially thrombosed aneurysms or aneurysms that have complex morphologies are typically not used with just coil embolization alone. The coils themselves often vary in diameter, length, and tensile properties, with the overall technique of coiling is that you start with a larger and more sturdy coil known as the framing coil to outline the aneurysm, and then as you continue to coil, you progressively use smaller and softer coils to pack the spaces and get that highest packing density that's possible. This is typically a very efficacious method to treating aneurysms with about 70% rate of occlusion. 30% will recur, and then 10% will go on to need retreatment. This is a very well-tolerated procedure with a morbidity of less than 1% in most cases. But the complications that we do see is that we'll have coil protrusion or migration into the parent artery, which can then be a source of thrombosis and thromboembolism leading to stroke. Coil embolization does have higher rates of aneurysm recurrence, especially when compared to microsurgery. And then when performing coil embolization, when inserting the microcatheter into the aneurysm, and typically those first few coils are the highest risk for causing an aneurysm rupture, especially or a re-rupture in a patient with subarachnoid hemorrhage. Some of the advancements in coil technologies are modulating the tensile strength and surface coating. As I mentioned before, the tensile strength is used to create coils that serve different purposes. Some of them are framing coils, and some of them are more used to increase the packing density. So as companies are coming out with softer coils, we can treat both smaller aneurysms as well as aneurysms that may be ruptured by using a softer coil. Some coils are also being now coated with hydrophilic gel coatings, which can actually expand once they're deployed and interact with blood, as the hydrogel will absorb the water and then increase the actual volume of the coils itself to reduce the dead space and increase that packing density. As well as some aneurysms will have polymer coating coils that will promote fibrin deposition across the aneurysm neck to help better sequester it from the normal cerebral blood flow. And then over to the right is an angiogram of a ruptured case where a aneurysm was successfully coil embolized, and thus securing it from risk of acute re-rupture. Next topic I wanted to move on to was balloon-assisted coiling. Around the same time that coil embolization came onto the market, people were already using balloons in endovascular devices. So balloons soon started to be used as an adjunct to coiling, where the technique here is to intermittently inflate the balloon, occlude the parent vessel, and then this can help sort of as a artificial neck for the aneurysm to help keep the coils inside the actual sac of the aneurysm, and can help prevent coil herniation into the parent artery as the coils are being inserted into the aneurysm. These are typically used in saccular and wide neck aneurysms. We can do this for larger aneurysms as well as aneurysms with bifurcation. This is also very efficacious, slightly more efficacious than coil embolization alone, leading to 85% complete occlusion rates and a 15% recurrence rate. It's typically very difficult to do this in cases of giant aneurysms, and the complication morbidity rate is very simple, very similar to coiling alone. I wanted to show a quick balloon-assisted coiling case. This is a MCA bifurcation patient with a multilobed aneurysm. Here we can see the microcatheters in place. These two markers right here represent the balloon, which is currently deflated, and then the coils are being inserted into the aneurysm itself. And then at the end of the case, we have a very good coil mass situated within the aneurysm, and then everything comes out at the end. Moving on to the kind of next level of coil embolization, this would be stent-assisted coiling, where either a permanent or a temporary stent can be placed across the neck of an aneurysm, and this helps prevent coil migration. The first case of stent coiling was published in 1997. There's also a role for having dual stents, which the multiple stents can be placed in either a Y, a T, or possibly an X configuration for complicated bifurcation aneurysms, where you need more support to be able to keep the coils actually inside the aneurysm sac itself and prevent them from protruding into the parent vessel. These can also be used for sidewall aneurysms or wide neck aneurysms, so they have a slightly more indication. There is a lower rate of complete occlusion for stent-coiled aneurysms. This is likely due to their more complex morphology and locations compared to aneurysms that undergo just coiling or balloon-assisted coiling alone. And they are limited by the patient needing to be on dual antiplatelet therapy during these types of procedures. So that can limit their utility in being used in a ruptured case or a patient that has another contraindication to DAP due to their medical comorbidities. And there is a increased risk of thromboembolism from the stroke, from the stent itself, leading to stroke. So some of the technologies and emerging technologies that have come from stent coiling is that we've gone through multiple generations of stents. The first generation had an open cell design where there are very large pores within the stent to allow for microcatheters to be passed in or out and to hold the coil mass in place. So these were things like the Neuroform and the Neuroform EZ stent. Second generation stents had a closed cell design where they were much less porous, and they were also made from laser cutting machine factoring. So these would be stents like Enterprise and Solitaire. And the advantage that these stents had is that because of their smaller pore size, they did create somewhat of a flow diverting effect where they would actually divert flow away from going into the aneurysm to prevent thrombosis. And then moving on to the third generation of stent, we have both laser cut, braided, and a hybrid cell design where there's a mixture of both open and closed cell stent technologies to create more of a hybrid approach to doing these procedures. And examples of this would be the Neuroform Atlas, Icahn, Elvis, or Leo families of stents, and all of these have different subgroups within them from each company for different sizes and mechanical properties. Another advantage of this type of stent is that they do have easier deployment and better wall apposition to reduce the risk of migration. In addition, we also use temporary stents or retrievable stents. So these will be things like the Comaneci or the Cascade devices, where a stent is temporarily placed across the neck of the aneurysm. The coiling is done either through the stent or with a microcatheter, what we call jailed against the stent wall to deboss the coils, and then the stent is removed at the end of the case. So this photo here shows a Comaneci device where you can see the stent is deployed across the neck of the aneurysm here, and then there's a marker a little bit more distal, and then the stent is then removed at the end of the case, leaving the coil mass behind. So this is another MCI bifurcation case showing a larger aneurysm, multi-lobes. And this is some of the intra-op fluoroscopy showing that the stent was deployed. Here are the times of the stent here across the neck of the aneurysm. And then there's a microcatheter that is jailed, as I mentioned before, where the microcatheter is between the outside wall of the stent and between the endothelial lining of the parent artery, and it's depositing coils. And then at the end of the case, we can see that the stent remains behind with these the stent prime tongs here, as well as the coil mass remaining. And here's just a run of the end result. One of the big advances in the last 10 to 15 years within the endovascular space has been the advent of flow diversion, which I believe first gained FDA approval in 2011 with the pipeline embolization device, which is marketed by Medtronic. This technique is inserts a very low porosity stent to reduce the blood flow to the aneurysm, which would then cause thrombosis over the course of hours to days. And this may be combined with coiling. So this is a example of what a flow diverter may look like. There's a very high wire density causing very small pores within the stent, allowing for a much reduced rate of blood flow actually going into the aneurysm after it's deployed across the neck. They can also, flow diverters can also act as a scaffold for endothelialization and arterial remodeling, which takes place over the course of months to years, with the aneurysm mass eventually involuting after it's thrombosed and had a fibrin deposition across the neck. Flow diversion is most commonly used in giant aneurysms, proximal aneurysms within either the proximal ICA, cavernous and ophthalmic segments, or it can also be used in giant fusiform aneurysms, and there's increasing data that it's being used in the posterior circulation as well. Some of the limitations with flow diversion is that it can be technically difficult. The patients do require dual antiplatelet therapy. There is this phenomenon called device foreshortening, where the device is inserted and then it actually is a in its deployed state, it's much shorter than what the proceduralist intended it to be, which then may require the use of multiple flow diverters, or what we call telescoping flow diverters, when they're placed inside of one another to increase the length. Another limitation is that posterior circulation arteries have many perforators that come off of them, which are highly eloquent in nature and typically are not well collateralized. And flow diverters may cause a occlusion of these arteries, leading to a ischemic event. They are very efficacious, and they typically become more efficacious with prolonged periods of follow-up. But they do have complications such as delayed rupture of the aneurysm. They have been shown to be related to ICH periprocedurally, and this could be from when a very large aneurysm in a proximal location, such as a large cavernous ICA aneurysm, is flow diverted. That aneurysm was actually acting as a damper to the entire cerebral vasculature. Once that aneurysm is flow diverted, there are very rapid hemodynamic changes within the brain, which it may not be able to rapidly adapt to, and then lead to a parenchymal hemorrhage. And then we also I previously discussed the risk of occlusion of perforator arteries and leading to thromboembolism. And then there's also a risk of what is known as an endo leak, where there is poor stent wall apposition of the flow diverting device against the wall, and then blood flow can actually seep between the stent wall and the endothelial lining, which can then lead to problematic situations in a poorly thrombosed aneurysm. This is a very hot field right now within the neuroendovascular space. There's a lot of companies that are working on developing new pipeline flow diverter technologies. They're creating new stents that have different types of coatings or polymer coatings that offer reduced thrombogenicity. These would be devices like the FredX or the Pipeline Shield. And these types of coatings may allow for single antiplatelet therapy and could therefore expand their utility to being used in ruptured aneurysm cases. Companies are starting to come out with smaller and smaller flow diverters to access distal vasculature. So this would be things like flow diverting MCA territory aneurysms. And then there are some papers coming out recently about the development of bioresorbable flow diversion. Although this hasn't quite made it to market yet, this is a promising field where a flow diverter made out of either partially or completely biodegradable polymer could be used instead of the typical metallic flow diverters. These could reduce the rate of thrombosis and intimal hyperplasia, leading to stenosis in late phases of a patient's treatment of their aneurysm, with the goal of these stents being completely resorbed after a year or two. And then once the stent, and the theory would be that once the stent is completely resorbed, the patient may then stop antiplatelet therapy after stent resorption. So this could have a lot of applications, especially in a younger patient population, where it would not be desirable to have them on lifelong antiplatelet therapy for decades and decades. Most of these stents would be fabricated from polymers, but there are reports of developments of bioresorbable metallic flow diverters, which we may see coming through the pipeline soon. Here's a case of a flow diverting or of use of a flow diverter. This is a patient that had a cavernous ICA aneurysm that was causing cranial nerve palsies. As we can see, and this is the pre-treatment angiogram, there already is some slow flowing of the aneurysm and likely partially thrombosis, but thrombosed aneurysm. However, the patient was still having symptoms from this. Moving on to the actual deployment of the flow diverter, it's really hard to see on the native images, so I outlined it in red. The flow diverter was placed along the cavernous segment of the ICA, and then you can see as the aneurysm is almost completely gone on follow-up angiography. There's just a very small amount of blood right here at the end, indicating that the aneurysm was undergoing active thrombosis already. The last topic I wanted to get into, and Dr. Keller and Dr. Majidi are going to delve more in depth into this, are the use of intrasaccular devices. These are the deployment of flow diverting devices actually within a aneurysm sac itself to cause thrombosis. They can also be used with adjuvant coiling. They do not require antiplatelet medications, so they do have a lot of potential benefits. They can be used in saccular and wide neck bifurcation aneurysms most classically, and they can be used in both ruptured and non-ruptured cases. Some of the limitations for these devices is that most aneurysms that we see may not be amenable. It's really that the aneurysm morphology has to fit the type of intrasaccular device that's planning to be deployed. And they do have a high degree of technicality that's required during the deployment of these aneurysms, as the dome of the device needs to sit very well within the dome of the aneurysm. And then one thing I haven't mentioned before is the cost of these devices, but the intrasaccular devices are some of the most expensive devices that's used in aneurysm treatment, with a single device costing $20,000 or more. So that is certainly a factor to consider when we're selecting patients and candidates for these types of procedures. But they are very efficacious. Studies have shown that they can be have up to 90% of adequate occlusion of the aneurysm. One complication that specifically has been reported with intrasaccular devices is that there may be device compaction over time, where actually strengthen starts pulling away from the walls of the aneurysm, and then can lead to aneurysm recurrence. Some intrasaccular devices only target the aneurysm neck, which could allow for coiling of a wide neck aneurysm. So these would be things like the contour, nautilus, or neck stent, which are shown in the top right and then in the bottom two panels here, with this being the web device, the woven endobridge device in the top left. This is also a very active field within the neuroendovascular space with industry, and it's highly expected that the indications for using intrasaccular devices is going to expand over time to be used for most saccular aneurysms, and it may ultimately replace things like stent-assisted coiling as these technologies develop and we're able to get more and more precise intrasaccular devices. And then I just wanted to finish up with a few of the technology gaps that we still have in the endovascular treatment of aneurysms. Most endovascular technologies perform well and are designed to perform well in proximal anterior circulation aneurysms. However, when we start thinking about complex posterior circulation or distal anterior circulation aneurysms, that's where some of our devices don't perform as well. Things like fusiform or dolichoectatic aneurysms still remain extremely difficult to treat, even with the current technologies that we have, and many of these patients still suffer exceptionally high rates of morbidity and mortality despite our treatment. There is an expanding armamentarium of endovascular devices that's needed to be able to treat our ruptured aneurysms. As I mentioned before, a lot of these devices either require the use of single or dual antiplatelet therapies, which may limit their utility in the ruptured aneurysm population. Another thing that's needed within the technology is to reduce the risk of lifelong thromboembolic events, again, from many of these devices requiring the use of antiplatelet therapy. And then one last point, a lot of what we do within neuroendovascular is trying to fit our devices into the patient's aneurysm, or hope that the patient's aneurysm will fit with the current devices that we have, but there is not really yet a form of personalized endovascular devices. So this would be something like 3D printing a intrasaccular device that's custom to a patient-specific aneurysm. This is something that the field is likely to experience over the course of the next few decades, to be able to better personally treat patients on an individual basis. With that, I'll stop my talk here, and I'll take any questions, and if not, we can move over to, I believe Dr. Kellner is following.
Brandon, great summary. That was really, really excellent. And as you can see, there's been a lot of progress, but still there are gaps in the technology and a lot of active innovation in the field. If you stop sharing, I'll start my presentation here. And so we're going to transition fully into discussion of intrasaccular and neck bridging devices. And the advantage to putting something directly in the aneurysm is that you can avoid the aspirin and Plavix of a stent or flow diverter, and it widens the option pool for treatment of aneurysms with wide neck. Specifically, wide neck ruptured aneurysm are the endovascular challenges. And so here are my conflicts of interest. I'm PI of the Tornado trial, which is the trial that I'm going to discuss some of the details of. But for that, I don't receive any compensation or have any conflicts with this company. So this is the beast that this technology and trial attempt to treat. This is a wide neck ruptured aneurysm. And when you think about the treatment options for something like this, we've got clipping, and that is always an option. We've got balloon-assisted coiling. As you heard, Comaneci-assisted coiling is when you temporarily place a stent and then you remove it. The advantage to that is that you don't need to have long-term aspirin and Plavix, and you no longer have something in the vessel after removal of the stent. But while you're coiling the aneurysm, you have continuous flow through that stent. So some people like that over balloon-assisted coiling, which has temporary occlusion of the artery. Then intra-aneurysmal flow diversion, we are going to talk about today. Intrasaccular neck protection devices, which is the category of the device I'm showing you. And of course, flow diversion, where you're putting a flow diverter stent in the vessel. This is sometimes done for ruptured aneurysms. You might think, well, you're not completely stopping the flow immediately. Is flow diversion the best option for a ruptured aneurysm? And that is a challenge because you have to put that patient on aspirin and Plavix and still have a aneurysm that's not completely occluded at the time of treatment. But sometimes, like for a blister aneurysm, that is your best option, and we do occasionally do that. Intrasaccular devices have really mushroomed or blossomed over the last decade. There are numerous devices already on the market. The Webb device in the top left was acquired by Microvention and is something we regularly use in our practice. The Contour device by Ceres was acquired by Stryker. It's not yet available in the United States, but it's going to be available imminently. Here's a device called the Galaxy device that is still owned by a private company developing it. It's been used in humans, and we're about to start a trial, and that's what Shahram Majidi is going to talk about next after this. Then there's the Artis device, which was acquired by Medtronic, and there's a trial that's about to start with that device. And then the devices on the bottom here, the one on the right is what we're going to talk about today. This is the Nautilus device. And the unique aspect of this, as you can see, is that it comes out like a coil, and it is, and you position it in the neck of the aneurysm, kind of like a saucer to capture and hold in the coils that you're about to put in. So it's an assist device for aneurysm coiling that allows you to treat wide neck aneurysms. There is some evidence already. This is a device that was CE marked in Europe a few years ago. So there is a European experience already with the device and a publication on that. And so from that publication, we have an adequate occlusion rate of this device with coiling of 93%. From the Webbit trial, which is the trial that got approval for the Webb intrasaccular device in the United States, the adequate occlusion rate for Webb was 85%. And then Ceres, the device that was just acquired by Stryker, is 84%. And so you can see from at least the data that already exists, there is some potential benefit to the Nautilus device, which is what we're talking about. And the Nautilus device publications were also mostly with ruptured aneurysms, which have an even higher intraoperative risk, and they have a higher retreatment rate. So from that information, it was promising enough to try to bring it to the United States. And that's what the Tornado US trial is doing. It's an FDA trial, prospective trial with 4 centers in the US to get FDA approval to use this device in the United States. Here, there are numerous ways that treatment for aneurysms fail. On the top left here, we have recurrence after formal coiling, good old coiling. And that there was a publication a few years ago that gave a number of about 30% overall for coiling recurrence. Clipping recurrent septic clipping is very rare. It's reported to be about 1%. And in the center here, we've got the Webb device. This is the one that's already on the market in the United States. And this does fail fairly frequently in terms of some aneurysm recurring at the neck right here, where you have the device kind of push into the aneurysm a little bit. And that can happen to different degrees. In 0 here, you've got it happening a little bit. In 1 here, you've got it happening a little bit more. And then in 2, the entire device is getting pushed into the aneurysm. And in 3, you can see some of the aneurysm is recurring along the side of the device. In my last slide here, I gave you an adequate occlusion rate of 85%, and that's Raymond-Roy 1 or 2. But people are reporting that the Webb neck, the Webb complete occlusion rate is in the 50s. So does it really matter if there's some aneurysm at the base as the device pushes in a little bit? We don't know yet. This is a newer device, so we don't have the recurrence rates of hemorrhage for these yet. But there are some concerns that there's not adequate complete occlusion. And so that leaves space for new devices to come along that will help prevent this push in of the device and maintain perfect complete occlusion after the aneurysm's been treated long term. The second device on the US market that's an intrasaccular device is the Contour device by Ceres and now acquired by Stryker. That's on the right here. And this one, instead of completely filling the aneurysm with the device, you place it in the neck and it sits there and blocks the neck of the aneurysm and is a flow diverter. This one had a similar adequate occlusion rate to Webbit, and that's 84%. And however, there has been one, this is a fairly new device, there has been one report of the device getting pushed into the aneurysm. And so as you can see, that is the concern, is that as the water hammer effect that formed the aneurysm in the first place continues pushing, it might push the device into the aneurysm. And here you see that happen. Here's the device at the neck of the aneurysm. And then at follow-up 6 months later, you see the device has flipped and is now covering the dome of the aneurysm. And they called that the umbrella complication of this device. So there is a lot of room for innovation in this field. And the Nautilus might address some of those, as well as another few features I'm going to describe now. So another advantage to the Nautilus device, potential advantage, is that there may be a flow diverter effect because the metal coverage at the neck is very high. Most flow diverters have an 18 to 42% metal coverage, depending what flow diverter and where along the neck, where along the stent you're looking. The braids are fairly loose at the ends, and then they become the metal coverage becomes more dense in the center portion of the flow diverter to make sure that you're getting maximal flow diversion at the aneurysm neck, which you've placed in the distance, so it's right across the neck in the center of the device. The Webb device, which is the aneurysmal intrasaccular flow diverter that's available, that's 35 to 45% metal coverage, depending which device you choose to put in your aneurysm. And the Nautilus device has twice that, so it's 70%. And so what we're trying to figure out in this trial is, are we seeing a flow diversion effect where at the end of treatment initially, you might have a Raymond-Roy 2 or 3, and then that might progress to a 1 over time. So that might be another advantage of this kind of neck bridging device with high metal content. Here's the publication from the European experience. This is 41 patients. They were published at a single center. I believe it was in Hungary. And here you can see the Raymond-Roy 1, which means the aneurysm is completely occluded at the time of treatment, was a 73%. But then at follow-up, that increased to a 94.5%. And so we think that may be because of the flow diverter property of the device, that you have improved occlusion over time. That was also seen in 5 patients that were published from a Japanese experience, where 3 of those patients had immediate Raymond-Roy classification of 3, which means there's still some blood flow getting into the full aneurysm, or 2, which means the neck of the aneurysm was still exposed. But in 3 of those cases, it progressed to a 1 over time. In 1 case, it progressed to a 1 and then back to a 2. So overall, it seemed like there was general improvement in the occlusion over time. So that brings us to the US tornado trial. It's been undergoing. We've been It has been underway for a few years, actually, sorry, 18 months. And we've enrolled 47 of 57 patients so far. And these are all ruptured wide neck aneurysms. We've got 5 sites involved, Mount Sinai, University of Buffalo, University of South Florida, Jacksonville, and then a site in Bulgaria. The primary outcome is the proportion of subjects experiencing death or stroke in the treated territory. And then secondary outcomes looking at the complete occlusion rate, and then device-related serious adverse events. Here I'm going to show you how the device works, and I'm going to show you a few cases. So this is a device that is deployed through a microcatheter, just like coils. So it's a technique that we're familiar with. It requires its own catheter. So you put in a regular catheter, you deploy the device, and then you place it in the neck and you keep it attached with that catheter. Then you bring up a second catheter and put the catheter through the center of the device and begin deploying a coil or multiple coils. Here's a video of how that works. You've got it coming out like a coil, and then it forms a flat plate, and you can pull that plate down into the neck of the aneurysm, position it, and then you keep the microcatheter continuously attached so that you can reposition the device, push it forward if you need to, pull it back if you need to, and adjust its placement in the neck as the coils come out. And when the coils come out, they work with the device to hold the device in the neck. So hopefully this will prevent that kind of compaction that you saw with traditional coiling, also the compaction you see with the intrasaccular flow diverters getting pushed into the aneurysm a little bit. And so here are 2 cases I'm going to show you. Here's the first case is a ruptured MCA aneurysm. Here you can see the left ICA. Here's the left MCA. Here's the MCA bifurcation with a large wide neck aneurysm there. Here's another view of it. And you can see MCA here, and then M2 branches coming out of this area, and then a large wide neck aneurysm there. So the first move is to bring up the microcatheter for the device. And so this is the microcatheter for the device in the aneurysm. The microcatheter is right here. And the device is the Nautilus is being deployed in the aneurysm. And when it comes out actually in line with the catheter. And then when it completely exits the catheter, it flips 90 degrees. And that's when you know you've got it completely deployed, and you can gently pull it back into the neck as you see here. Then the second catheter, that's the second catheter right here, is advanced through the center of the deployed Nautilus device, and the microcatheter is brought into the aneurysm, and you begin coiling as you normally would. And so here is a radiographic image with partial coils, and you can see the Nautilus device is here, and the coils are partially deployed here. And so you have the ability with the Nautilus device to adjust it to optimize your occlusion and its position in the neck as the coils are coming out and they're working together to hold it in the neck. Here's what that looks like after complete treatment. And so you can see the Nautilus device is here, coils are in there, and this wide neck aneurysm has been treated endovascularly. Here's the second and last case I'm going to show you. So this is a ruptured basilar tip aneurysm. Here, this is not exactly aligned, so don't worry, it's not coiling in the subarachnoid space, but you can see how the device comes out, and then when it comes out, it flips. And you'll see that in a second, and then you pull it down into the neck. There you go, there's the flip. And then you see it position in the neck right there. And then once it's in, then you'll bring up the second catheter through it. And so here you see it position in the neck here, second catheter through, and that completes coiling. And here's a side view of that. You can see it nicely positioned there. And this is an aneurysm that we could treat probably with stent assist coiling or Y-stent coiling endovascularly. But this creates a nice solution that does not require aspirin and Plavix. This device you can place without any antiplatelets. So it makes it particularly suited for ruptured aneurysms. And then here's the final occlusion here. All right, thanks very much. And I'm going to pass it on to Shra Majidi, who's going to talk about the Galaxy device, which is another intrasaccular aneurysm device that the trial is about to begin.
Thank you very much. Good morning, everyone. Let me share my screen. So I will be talking about intrasaccular devices. Great presentations from Brandon and Chris. I love Nautilus device. It's great. It's very safe and effective. But how about we have a single device that we can deploy inside the aneurysm, and one and done, an aneurysm is fixed. That's why single intrasaccular devices are aiming to achieve. So let's see where we are and what the current generation of devices are offering. These are my conflicts of interest. I am a PI for CLE trial. However, I don't have any financial relationship with the company. So some background, as discussed earlier, aneurysm morphology, neck size, dome size play a critical role in decision-making for aneurysm treatment. Coiling remains a essential tool for aneurysm treatment across the board, and for aneurysm like this, or even a small ruptured pica aneurysm like this. With the current technology of coil, we are able to offer this treatment for this patient. However, when it comes to wide neck aneurysms, they present a very unique challenge that traditionally existing endovascular or open options are not adequately addressing the aneurysm treatment. So if you look at the conventionally available therapy for wide neck aneurysm, this was a large observational study done years ago. As you see here, endovascular therapy, conventional endovascular therapy for this aneurysm, only 39.8% complete occlusion and less than 50% adequate aneurysm closure with endovascular therapy. Similarly, for surgical clipping, also it's a relatively low aneurysm cure. That's why over the years, we had some assisted therapies offered for this challenging aneurysm, such as balloon-assisted coiling, which increases the rate of aneurysm closure, however, also provides some added adverse event during procedure, like increased risk of thromboembolism or vessel injury. Recently, we had stent-assisted neuroform atlas study published, which was addressing stent-assisted coiling for anterior circulation and posterior circulation wide neck aneurysm. As you see on the left side, primary efficacy endpoint, which was aneurysm closure and also patency of branches, was relatively high, definitely higher than primary coiling. However, with some increased rate of thromboembolism compared to primary coiling, as you see here, 4.4% for anterior circulation, and similarly 3.4% for posterior circulation, but increased aneurysm closure, however, with the expense of putting the patient on dual antiplatelet therapy. Over the years that we had some assisted devices have been introduced to the endovascular field to address this really unmet needs in an aneurysm field. As you see on the left side, web device or Comaneci, which is a temporary stent that you put across the aneurysm neck to support the neck while you're coiling the aneurysm. The advantage over stent is you don't have a flow arrest while the Comaneci is up, and it is temporary. You would take it back when you're done. However, there are some reports on a higher rate of thromboembolism in these cases. There was a study called Success study that we participated, multi-center studies. The results will be published soon. The preliminary result from Success is showing that Comaneci-assisted coiling is pretty successful in offering durable treatment for this patient. And also Contour and Pulse Rider and other types of neck bridging, which has been introduced in the recent years. We will talk more about Contour, but Pulse Rider, due to the challenges in device placement and low occlusion rate, didn't really gain attraction in the field. How about intrasaccular devices? A single device, one and done, fast, low procedure, fluoroscopy time, and also eliminate the need for antiplatelet therapy. Pretty attractive, very appealing. Web is the only FDA-approved intrasaccular device currently in the US. It's a single layer of nickel and platinum wires that braided together with some platinum markers at either end and each end. It has a metal density of over 65% on the sidewall, which actually increases even more on the over the aneurysm neck with the platinum markers present. It ranges from 3 millimeter to 11 millimeter and covers aneurysm from 4 millimeter to 9 to 10 millimeter aneurysm. So we had very popular outside the United States. Europeans, they have over decades of experience with this. Recently, we had Webit trial in the States, which enrolled 150 patients with wide neck bifurcation aneurysm. Over 1/3 of them were ruptured aneurysm. Extremely safe, as you see. There was no significant thromboembolic complication. There was only one primary safety event, which was a ICH 30 days after procedure in the same territory. And 12 months, only 54% complete aneurysm occlusion was observed, as you see here. And adequate occlusion was essentially Raymond Roy 2 was 85%. Extremely safe, reasonably effective. Recently, we had 5 years Webit trial result. It's showing that 87% occlusion that we saw at the end at 1 year is durable. When you have a complete occlusion with Web, it's gonna remain occluded. And moreover, there was no rebleeding, aneurysm re-rupture among all those patients with suboptimal occlusion over the course of 5 years follow-up. And there was no device-related adverse event. And also the retreatment rate was only 9%. Again, pretty safe and reasonably effective, 9% retreatment rate. However, 54% complete occlusion is still a questionable result. And when we look at the Web experience in the literature outside Webit trial, the retreatment rate is much higher, up to 20%. Therefore, although Web is a good attempt of intrasaccular device, a single device, eliminate the need for aspirin or Plavix. However, because of the relatively low complete occlusion rate and relatively high retreatment rate in real-world experience, we still have to search for a better intrasaccular device. So I have some cases that we've done here at Sinai. This was a 11 millimeter basilar tip aneurysm. A 54-year-old gentleman presented to us. He was a very educated person. When he found out about this aneurysm during headache workup, he started researching about it. The first thing he told me in clinic was probably Web would be a good device for my aneurysm. I read about it recently, so which was pretty fascinating. So we decided to treat with Web. I think for basilar, top of basilar or ICA T aneurysm, Web is an extremely effective device. So we deployed this Web here, as you see in the middle of the screen. And on the right side, as you see, the immediate angiogram is showing very significant flow stagnation inside the aneurysm. which actually shows that we have a very nice sealing of the aneurysm neck with the web device. The technique is you oversize the width of the device based on the aneurysm size. That will seal the aneurysm neck, and that will increase the likelihood of aneurysm closure in the follow-up. And this is a 6-month follow-up for the patient, had a complete aneurysm occlusion and with no residual. However, the challenges with the web sizing the device, and also the likelihood of device displacement has been ongoing debate and challenge in the field. So for instance, this patient with a large left MCA bifurcation aneurysm came to us last year. As you see, large aneurysm with a small daughter sac here in the 11 o'clock here. So we decided to treat with web, pretty straightforward, fast procedure. Single device was placed, and a very nice stagnation, as you see on the right side, which give us a confidence that this is a properly selected size, nicely sealing the sidewall and the neck of the aneurysm and preventing the flow of the contrast. However, in 12 months, as you see that there is a little displacement of the web, probably a little shrinkage, as you see on the left side here in the arrow, that the other sac is still filling, and in the lateral view, also the base of the aneurysm filling. This is relatively common in real-world experience with web. So as you see on the right side, we had to go and do a stent assisted coiling for this aneurysm residual to cure this aneurysm. So really, this is one of the limitation of the device, complexity of the size selection, and also high rate of device displacement and subsequent aneurysm residual despite proper sizing. So recently we had Contour in the United States. This is only approved to be used within the clinical trial. This study has been completed. We will have the result soon. Based on the available literature, it seems like the aneurysm closure rate is higher than what we see with web, which is a good advance. However, also higher rate of thromboembolism and branch occlusion has been reported with this device. We're going to have to wait to have the final result of the trial to be able to comment about the efficacy and safety of this device. And the most recent endovascular intrasaccular device is SEAL device, which is a saccular endovascular aneurysm lattice. This is now it's a single device similar to web. It has a dual layer, and as you see here, it comes in two different shapes. One is on the left side is called SEAL base, which is more flat for a shallow aneurysm. And the right side is called SEAL arc, which has a top loop. It aims to address some of the limitations and challenges that we faced with web. It's more simplified sizing, softer top portion, and also covers aneurysm up to 16 millimeter. Web was only covering up to 9 to 10 millimeter. So outside the States, there was a pre-seal trial, which was done in Colombia and Pakistan with 33 patients with wide neck aneurysm. They demonstrated 74.1% complete occlusion and 85.1% Raymond Roy 2 at 3 months. Pretty convincing and high numbers. with no adverse event and straightforward device deployment. Now we are ready for CLIT IDE trial in the States. Sinai will be one of the sites. The first patient was enrolled yesterday at Montefiore and was successfully placed. And we are hoping to get activated here at Sinai and start enrolling in this trial. So if I want to conclude, the new generation of intrasaccular device has shown to be safe and reasonably effective for treatment of wide neck aneurysm. When it comes to wide neck aneurysm, it looks like flow diverting stent has addressed the sidewall wide neck aneurysm. But for the wide neck bifurcation aneurysm, because you have to maintain the patency of branches and also high efficacy of aneurysm closure, both Nautilus as a neck bridging device and also intrasaccular devices are promising technologies that I think in the following years we will continue to see the evolution of these devices until we have a device which is safe to deploy and also provided durable, complete aneurysm occlusion. With that, I thank you for your attention.
Thank you. Let's open it up for discussion.
Thank you, guys. Those were really beautiful presentations. Brendan, I have a question for you and a question for Chris and a question for Shahram. You said that the incidence of detected aneurysms is growing. What do you think the reason for that is, Brendan?
I think that it's just because we're likely scanning more patients for, and we have more indications for scanning patients, and then we're finding these aneurysms more incidentally. And as we're catching these aneurysms, the literature is starting to realize that they may be more common than we were thinking before.
Do you think there are any implications for the way we manage unruptured aneurysms of that observation?
Yeah, I think so. Because of the relative rarity of subarachnoid hemorrhage, and then as we're starting to realize that people that have unruptured aneurysms are more common, I think we need to be much more selective in figuring out which patients are actually at a high risk of rupture. As we know, it's a very small subset of patients that have aneurysms are at a true risk for having a subarachnoid hemorrhage. So it does warrant us being more careful in who we're deciding to treat.
Yeah, I completely agree. Because if the incidence of unruptured aneurysms is growing, we should see an increase in subarachnoid hemorrhage rates. If it's just due to detection, due to increased sensitivity or indications or access to technology, we should see the measured rate of rupture of an unruptured aneurysm decrease because we're detecting more of them. So this could have a big impact on the natural history studies, particularly if the numbers are as robust as you suggest. It sounded like you're showing a doubling or tripling of, or even more of the expected rate. And if that's the case, that really turns all of the unruptured aneurysm data on its head.
If I may add here, Dr. Batterson, we actually are, I mean, this is quite a hot topic, and we just got a grant from the B Foundation to study the disparities between detection of incidental aneurysms in the Sinai system versus the HHC system, to try to see if also access to care and socioeconomic background and racial disparities may be playing a role in such an increased incidence of detection.
Great, thank you. Chris, I have a question for you on the Nautilus. It looks like there's some asymmetry when the device flips from vertical to horizontal, so that you have an eccentric deployment. Is that adjustable? Like once it flips from horizontal, from vertical to, and that could be a problem, because if the neck of the aneurysm is asymmetrical and the near side is too close to the branch point, that could be a problem. Is that adjustable after you flip it?
There are a few challenges in deploying it. But we have found that you can generally get it done. But the first challenge is, as you saw, the device comes out in line with the catheter. So if you have a little bit of a shorter aneurysm, and sometimes you have to begin deploying it really in the neck, and then you have to actually, as you're deploying it, sort of advance it gently. Then it flips, and you have to pull it back gently in a shorter aneurysm. So the aneurysm height is a limitation. And you're right, there's a little bit of asymmetry because the microcatheter wire is still attached, not exactly in the center, but a little bit to the side. You can't really rotate it. You can't rotate it. If you're asking if there's a rotational ability, not really. You can pull it down, and then if it doesn't fit correctly, you can push it back in and try to pull it down again. Or what we have been doing is you get it partially deployed, you get it fully deployed in the neck, but not in exactly the position you want. And you know that the coils are going to interact with it. And so as the coils interact with it, generally that will push it into the neck in the right spot. So you rely on that coil neck bridging device interaction to squeeze it in the right spot.
Cool. And for Shahram, I was going to ask you, what is the average dose of radiation that a DSA for an aneurysm gives you, and how does that relate to the doses we use in fractionated radiotherapy? I mean, I know the answer, but I would just want you to discuss that a little bit.
Well, on average, and the fluoroscopy and radiation dose in aneurysm treatment doesn't reach the threshold that could give harm to the patient in general. The fluoroscopy time is a little more, could be much higher during fistula or AVM treatment. So on average aneurysm treatment with coiling or other devices, probably fluoroscopy time of 30, 40 minutes maximum. However, when it comes to single intrasaccular device, that could be done even less than 10 minutes, 10 minutes, sometimes single digit. I don't think that should be the primary goal here, because the primary goal is the aneurysm, durable aneurysm treatment, because probably doesn't affect the patient, whether 20 minutes fluoroscopy time versus 8 minutes, but that's something.
I think that this is a risk that is not talked about. It's underestimated, and particularly since you have retreatment as a high likelihood in a lot of these cases. My understanding is that you're talking about 200 CGY, something like that, for the average aneurysm, and more for fistulas. And this if you keep repeating that, ultimately you do end up with significant radiation doses. And the other thing to consider is the long-term risk of dual antiplatelet therapy, which is estimated in patients who've had stroke and TIA as an indication. And so most of the data on the long-term risk of dual antiplatelet is focused on comparing the risk of stroke if you didn't use it in someone who had a TIA versus the risk of bleeding events if you do use it. But our aneurysm patients are very different because they haven't necessarily had a stroke or TIA. So the indication is different. And I tie all these three questions together because if the true risk of rupture of an unruptured aneurysm is much lower than we thought, and the added very small risks of radiation and dual antiplatelet therapy before you get to your dream of not of intraaneurysmal devices, we should just be careful on our patient selection.
Absolutely.
Those are really beautiful. And I'm sure you could go on about what you want to do in the future in terms of developing new devices and how we're going to help you on the 26th floor. Shahram is just getting a grant going on endovascular transvenous technology development, and he's going to be leading the charge at Sinai in our brand new biplane animal angio facility on the 26th floor in the coming years. So we're very excited for what you're going to do.
That's very exciting, and I'm grateful for the support.
That was tour de force. Any other comments or questions?
I have one question for Dr. Majidi, Dr. Kellner. Brandon was a really good Red Chief on Monday for one day, and we were talking about sort of prophylactic MMA embos for people at risk of chronic subdural, which is becoming increasingly common. I'm just curious what your thoughts are about these patients going on dual antiplatelet. While you're doing aneurysm treatment, they're getting these follow-up angios anyways. Constructing a trial or the utility of prophylactic MMA embo in that population.
You want to take that, Sharon?
Well, prophylactic MMA embo for subdural hematoma in patient who never had subdural. I think probably it has to be very extremely very well selected patients. I don't see large evidence to support that. In patients with subdural who have prior subdural and resolved, but now for various reasons need to be on anticoagulation or antiplatelet, I think there's justification there. But in patient who doesn't have subdural, there's although MMA embolization is extremely safe procedure, I think we need more evidence to be able to offer them.
I agree. I think the incidence of a chronic subdural is about 40 in 100,000, right? So the risk to a person who doesn't have one is pretty low, even on aspirin Plavix. So I think prophylactic, I wouldn't engage in that, but some people are doing MMA embo for acute subdurals, knowing that a small percentage of those will go on to form chronic subdurals, and maybe you can prevent that. We, in general, haven't been doing that. There's the trials that are coming out don't address that situation. But I think that's one situation in which there are a few people around the world who have been talking about prophylactic embolization for acute subdurals to prevent the potential for a chronic subdural down the road. I think we need some evidence to support doing that, though.
This is great. Thank you, everyone, and great discussion. If there are no other comments, we'll see you next week for our case conference meeting.
Thank you.
Great. Thank you. Beautiful talks.